Thanks, Ralph. So I've tried to make this as friendly as possible. Hopefully, I've achieved in that goal. Uh, but let's just get going. So this is the current treatment landscape available for patients with sickle cell. Hydroxycarbamide blood transfusion has been the cornerstone of treatment for decades now. L-glutamine, which is not available in the UK, is a licensed treatment for sickle cell. It had FDA approval. Has some evidence that it does reduce pain by about a third in some patients, but it's quite poorly tolerated. And I caught the tail end of the last presentation from Keisha. I think he sort of touched on crizanlizumab and Voxetor, which were both withdrawn in 2024. Curative options are transplant options, and those have different flavors. So allogeneic stem cell transplant in the UK, fully matched sibling transplants are commissioned. Alternatively, haploidentical transplants as part of a clinical trial called Redress, and Casgevy, which is part of a managed access program, is an option with fairly rigid criteria. There are some new generation options which involve sort of gene editing in various guises, which we may touch on briefly at the end if we've got time. And then in development, there are some quite exciting treatment options coming down the line, long-awaited options. So probably the one that's probably most advanced are the pyruvate kinase activators, which I'll talk about. I have a dedicated slide for that on its mechanism. It's quite complicated. There are hemoglobin polymerization inhibitors, which sort of stops one of the early stages of the sickling process. And Voxetor is one of those. We'll talk about its new iteration in the presentation. Novel gene therapy, including in vivo gene therapy, which is sort of the holy grail of gene editing, which will likely make gene editing a more viable option to a significantly increased proportion of patients, particularly those in lower middle income countries. And the one I missed at the top was the targeted fetal hemoglobin inducers, which hydroxycarbamide is one of. And there are new drugs which have gone into phase 2-3 trials that may well be available in the coming years. So what I didn't want to do is forget about what's available at the moment, because again, as Keisha mentioned, there is good evidence that drugs like hydroxycarbamide work well for a significant proportion of our patients, and for a variety of reasons, which I don't really have time to go into today, are not fully utilized. The baby hug study, sort of tens of thousands of patients across different nations, different healthcare systems, show clear evidence for those patients with sickle. So those patients with S beta thalassemia gene, S beta thalassemia, S beta thalassemia, S beta thalassemia genotypes. Sorry about that. Those patients often those patients should be initiated on this drug for 9 months. So from a very early age, that we have guidance now in the UK that suggests that all patients with those genotypes should receive this drug. It's slightly more complicated for those with HBsC disease for a variety of reasons, and those need to be taken on a case-by-case basis. Though we've seen some progress over the last, 50 years or so in the UK, there is a significant discrepancy in median life expectancy between those patients who have sickle and those that don't. So sickle cell patients, unfortunately, have a reduced life expectancy compared to their age, also ethnically matched peers, by about 20 or 30 years. But blood transfusions, hydroxycarbamide, and penicillin, all quite conservative measures, have made a significant difference to mortality. So I told you that I was going to sort of touch with a bit of detail, just a little bit of detail on current therapies. So hydroxycarbamide works, and one of the beauties of the drug is it works via a multimodal approach. It doesn't target one element of the disorder, which I think is one of the challenges with some of the newer drugs, that they target a single element disorder. And unfortunately, sickle is a very complicated pathology to overcome that. So hydroxycarbamide, as we all know, increases fetal hemoglobin, and that fetal hemoglobin competes with the sickle hemoglobin, reducing sickling. It hydrates the cell, and the cells become larger, so it can accumulate more hemoglobin, so it can carry more oxygen, and limit some of the hypoxic effects of sickle. But not only that, that hydrated cell is more pliable, so it's able to maneuver through the small blood vasculature that, and as a consequence, it leads to less hemolysis. It reduces adhesion molecules, and crizanlizumab, which targeted T-selectin, which is one of the adhesion molecules, hydroxycarbamide does that as well. So it reduces that stickiness of the cell and reduces the adhesion of the red cell and other cells, blood cells, to the inner lining of the vasculature. Nitric oxide depletion, I think we talked, or was mentioned again, I caught the last tail end of the last presentation. And one of the issues with ulcers and sickle is this depletion of nitric oxide. So all sickle cell patients, all patients with hemolytic anemias, are significantly nitric oxide deplete, and that affects the vasculature and makes the vasculature quite stiff, and that can result to a variety of things, including ulcers, which was mentioned. We know from various studies, and the MESH study is, again, quite a large study, quite old, the data quite old now, really quite valuable. Significant reduction in painful crisis, significant reduction in acute chest syndromes, which is the most common cause of mortality in sickle patients, sickle adult patients, and also increases transfusion requirements and mortality or morbidity. So all very good things, but it doesn't come without risk. And sort of making sure that as sort of the nursing team, that you're aware of those risks. And as some of you nurses are running hydroxycarbamide clinics, it's really important that these things are forefront in the mind. So initiation, making sure the necessary blood tests are done, sort of careful counseling about things like fertility and teratogenicity are quite important. Though the risk to the unborn fetus, there's good evidence for sickle and other disorders where hydroxycarbamide is used, that risk is relatively small. It's one that should be discussed, because this is something that comes on not infrequently. And marotoxicity is one of the major things. I've got a slide, the next slide, that talks about some of the toxic effects. So marotoxicity is an important feature that we just need to be mindful of, and the necessary measures like taking those blood tests to ensure that that's not the case. And sort of talk to those red flags. So when someone's absolute neutrophil count is low, their platelet count low, or their retic count's low, you hold, you seek advice, and you restart appropriately. There are significant misconceptions associated with hydroxycarbamide. We can't sort of ignore those, particularly in relation to this being a cancer drug being used for chemotherapy. It is used as an adjunct for some types of aggressive chemotherapies, but just to reduce blood counts. It doesn't actually have any impact on the cancer itself, so it's technically not a chemotherapeutic agent. This slide tries to illustrate the changes, the morphological changes, the changes to the blood cells that occur as a patient starts hydroxycarbamide. One thing that I wanted to make, and I'm sure the audience are quite aware of this, is that the effects don't happen overnight. So a patient needs to, and the patient needs to be appropriately counseled that it's going to take time for the effects to occur to the blood cells, or those blood cells turn around. But also, as a consequence, it will take time for those effects to be seen from the patient's perspective. So the increased energy, the increased hemoglobin, the reduced number of sickle cells, so the reduced number of sickling episodes, can take weeks and sometimes months before they start to take full effect. And if there isn't sufficient time to ensure that that happens, and ultimately what tends to happen is the patient gets fed up, particularly if they experience some of the side effects, and as a consequence, they don't tend to get the full benefit. This is a slide that's really looking at sort of the side effects. Some of the early side effects are gastrointestinal side effects, which often are resolved by taking the medication at night, and they're often self-limiting. Myelosuppression, and we talked about just monitoring and making sure that if a patient does start to experience symptomatology that suggests some myelosuppression, that they are appropriately counseled. The nail and skin changes shouldn't be ignored. They are self-limiting. They will reverse if the patient decides that that particular side effect is something that they can't tolerate. Then stopping the drug will reverse those side effects. But these don't always happen to every patient. So trialing the drug to see if it works for them. And I've started patients on this drug with a lot of reluctance, and months later, they become really quite strong advocates because it has been life-changing. So, and effectively what we try and do is we start patients at a dose of about 15 milligrams per kilogram, and then up titrate. And this is the thing that we don't do particularly well. Up titrate to about up to by 5 milligrams per kilogram every 3 months to a maximum tolerated dose, and the maximum dose is about 35 milligrams per kilogram. Monitoring and toxicity, we would affect. Yeah, as I've sort of alluded to before, I probably don't need to overemphasize that element. Blood transfusions, I'm not going to sort of touch too much on blood transfusions. I'm sure you know all about this. Very effective drug in the acute, so very effective intervention in the acute and the prophylactic, the chronic complications of disease. But there are things to be mindful of. Because the vast majority of our donor pool are Caucasian, white Caucasian, and the vast majority of the patients with sickle are Black, African Caribbean individuals. It means that the risk of developing alloantibodies is significantly increased than the indigenous population. So we just need to be mindful of that. There are things to set that. We do have an extended match phenotype for patients with sickle, but that isn't all that comprehensive. So there is a risk, and what we certainly don't want to do is to limit our patients by allo-immunizing them so that when they do need a transfusion, then that's not available to them. There are risks associated with it, sort of hemolysis, allergic reactions, hypotrally, other more mild, more easily managed things like citrate toxicity, hypovolemia, things that should be mindful of, because these can make a transfusion quite difficult for a patient, particularly those on chronic transfusion programs. So we just need to be mindful of those and manage those appropriately. And then more longer term things like iron overload, and making sure that we're looking for those alloantibodies, and we're monitoring for potential iron overload and the potential complications associated with that. This is the cornerstone of treatment, the gold standard treatment, disease-modifying therapy for our patients with sickle. Now, to go on to the curative options, these come in really two flavors. One are the allogenic transplants. In the UK, we have fully matched sibling transplants, which are commissioned, where a sibling donor who has a 10 out of 10 HLA match donates to who either has an AA genotype or AS, so sickle cell trait, siblings can donate. And the data for that is really quite exceptional. it is a chemo-free. It's a chemo-free option which involves antibody therapy and some radiation as part of the preparation of the bone marrow to receive the new stem cells. And then the other option is a haploidentical transplant, so a half match, a HLA half match, which doesn't necessarily have to be a sibling. It can be a relative of any type. And that does require significant chemotherapy, conditioning chemotherapy, but does increase the options to patients. We know that only about 15 or less than 15, about 12 to 15% of patients have a fully matched sibling, but over 95% of patients have a identical match. The only challenge is that the haploidentical transplant is part of a clinical trial for adults. For children, that's kind of care. So that needs to be borne in mind. And then the other option is an autologous stem cell transplant, which is part of a managed access program, which I've talked about, only available to those in the UK over 12 with HBSS or HBS beta thalassemia, beta naught thalassemia. And the data for this is new. The first patient who was part of the trial was only transplanted just over 6 years ago. So the data is all quite new, but is really quite encouraging. Significant reduction in vaso-occlusive crisis and almost no hospitalizations following the washout period post-transplant. So I kind of touched on all of these, so I won't go over this in any detail. The only couple of things to be mindful of is that with obviously you don't require a donor, it's your own stem cells that have been modified for Casgevy, for the gene editing option. And because it is your stem cells, you don't get there's no GVHD risk, but the chemotherapy that you are given to prepare the bone marrow is significant. It's fully myeloablative, so the busulfan that you receive is something that needs to be carefully considered. So what makes things slightly complicated is that the criteria for inclusion for the clinical trials or to receive a fully matched sibling transplant or Casgevy is all slightly different, but effectively it's those patients that have severe disease, and severe disease is classified by a number between 2 to 3 crises per year for several years, in the case of Casgevy for 2 consecutive years, and or a severe complication of disease such as recurrent vaso-occlusive crisis, sort of ongoing hypismal episodes, history of stroke, and all of these things need to be carefully considered. And that's probably it. However, that being said, this is curative therapy. So effectively what you're doing is you're halting the disease where it is, you're stopping the progression of sickle and this sort of indolent, sort of ongoing organ damage as a consequence of this repeated, often unidentified sort of a sickling process, significantly increases life expectancy and halts disease progression in its tracks. So I'm going to skip through that one. And this is really just data on the number of patients that have received these sort of the allogeneic options. It's really positive data. And for those patients who have severe disease who are eligible for these options, I actively encourage them to take one of them up, because what we do know is, unfortunately, there's no such thing as good sickle. It's a disorder that continues to have a significant effect on organ function. So for those patients who start off with a relatively good disease, time is and can sometimes give rise to significant deterioration. So I encourage all of our patients to consider these options. And this slide is really trying to illustrate the fact that, particularly for the gene editing option, that this is not a straightforward journey. It's a long, quite committed option. With it comes risk and comes commitment and dedication. So what we need to make sure is that a patient who wants to go this route is fully aware of what this entails and is willing to stay the course. We offer quite significant support, particularly from a psychological perspective. For those patients who we transplanted, realize how much of an impact this has on a patient's mental state. And we just need to sort of bear all of those in mind. This is a journey of about 2 years, 18 months to 2 years for a conventional transplant. For those patients who are receiving gene editing, is significantly longer than that, particularly given the fact that that modification of the stem cells that have been collected take up to 6 months. So it is a really big entailment, and the patient needs to be fully on board with all of that. We at Imperial are the regional authorized referral center. So all patients for Casgevy within the region get referred to Imperial, to Hammersmith, and St Mary's. And what we encourage those referrals is to have sufficient data for us to make a balanced decision about whether a patient is eligible for this treatment option. And these are some of the criteria. Given that we need to have a good idea of the disease state, it's useful to know how many crises the patients had, particularly over the last 2 years, any organ damage, because that helps us determine whether they're eligible for treatment, but also if their treatment is going to be too much from an organ perspective for them to tolerate. And also from a family perspective, whether they've got siblings and whether those siblings are in good health, whether they have sickle cell disease or not, because obviously that precludes them from being donors, and where they are geographically. As I said, I've sort of touched on the psychological element of this. It's really, really important. The psychosocial element is something that we, as speak to myself as a clinician, we often sort of underestimate. But this has really, really significant impact on how a patient progresses and ultimately the outcome of this really quite transformative therapy. So we need to sort of be mindful of all of this. We need to consider that this is a chronic illness. So we're not treating cancer patients here. We're just trying to sort of adapt to, an approach to those patients who have an acute complication, which is the cancer diagnosis, and the resulting treatment subsequent to that is very different from a group of patients who have lived with the disorder for decades. So we just be mindful of all of that. We also need to be mindful of the complications, the additional factors for a group of patients who are underrepresented. There's a lot of bias, a lot of racism associated with institutional racism that exists within the NHS, and makes it very difficult for them to sort of navigate the system. So those also need to be mindful, because what we don't want to happen is those patients who are eligible for treatments not to get them because of any of these factors. So I'm going to touch on these quickly. I know that I don't remember when I started, so I think I'm sort of getting close to my time now. So I'll do these relatively quickly. So these are the new oral agents that are coming down the line, and hopefully they will be available to patients with sickle in some cases, the coming months, others a bit longer than that. So mitapivat, got a slide on exactly how this drug works. So this is a pyruvate kinase activator, which has done very well through the clinical trials and significantly reduces the number of vaso-occlusive crises in those patients that respond. So those patients who have at least an increase in hemoglobin by, which is American money, so 10 grams per liter or 1 gram per deciliter, then those patients have a reduction in the number of crises they have of about 25 to 30%, which is significant. And that increase in hemoglobin and reduction in hemolysis has a significant impact on quality of life and all others. There is a couple of other drugs that, one that I think a few of the centres within the region have been involved in coursework A and coursework C for Codeveloped, which is a complement inhibitor. Unfortunately, the clinical trial data isn't all that encouraging, so I suspect that drug will not go much further. Though I think space is something that will likely be explored going further, and new agents will come down the line, because a complement activation is a significant, or dysregulation is a significant feature in sickle cell, and ameliorating that I think will help modify disease. And then there are fetal hemoglobin inducers, and there are a couple of those that are quite beneficial, but they're in early trials at the moment, so we'll see how they go. As promised, mitapivat, this is effectively how it works. So this is a drug that was initially developed for a group of patients with another red cell disorder called pyruvate kinase deficiency. And this drug increases pyruvate kinase activity. And what PK does in this situation is that it increases 2,3-DPG, so it decreases 2,3-DPG, which as a consequence increases the affinity of the sickle hemoglobin to oxygen. So it holds onto that oxygen a bit longer. And as I'm sure you know, that it's deoxygenated hemoglobin, sickle hemoglobin, that starts to polymerize and starts to sickle. So if you can make the hemoglobin hold on to that oxygen a bit longer, it doesn't sickle, and as a consequence, you don't see any of the consequences of sickling. The other thing this does is it increases ATP production. So ATP's it's the energy store within the blood cell. So if you can increase the sort of storage capacity, then you can ameliorate some of the complications, some of the challenges that red cell has to overcome because of the fact that it is sickling. So both of these things have shown significant benefit in those patients with sickle cell. These are some of the drugs that are in even earlier phase clinical trials. Avapivat, we are involved in Hibiscus 2. Some of the patients on that trial, and that's the sort of the phase 3 study looking at Avapivat in sickle cell. Again, very promising results. And Mitapivat is another PK activator. So pyruvate kinase is quite deeply embedded in some of the treatment options. There are 3 agents in clinical trials at the moment, and Mitapivat is probably the one that's furthest away, but it's a more potent pyruvate kinase activator, and the hope is that it will be even more effective than its 2 predecessors. And then osivelotor is the new iteration of these hemoglobin polymerase inhibitors, similar to voxelotor, supposedly more potent. And we will see how well it goes. We're about to open, hopefully over the next 2 or 3 weeks, the osivelotor study at Imperial, and we shall see. I think I'm coming up to my final slide. Sorry, I'm running a bit over. But I just wanted to talk about what these 2 drugs. So 2024 was a very interesting year. There was a lot of fanfare that came with crizanlizumab and voxelotor after decades of no drugs for sickle cell, the first genetic disorder. We had 2 drugs made available in the same year, and them both withdrawn in the same year, which was unheard of. And some of the reasons why this happened is, as Keisha sort of alluded to with crizanlizumab, that the study population was really inconsistent with the real life experience of a lot of patients. So as a consequence, particularly the phase 3 clinical trials or the phase 2 clinical trials, which are run in part during COVID, limited mainly to US sites, and were not really representative of the healthcare system in any other sort of environment. And that, along with poor clinical endpoints, I think were significant factors in the failure of voxelotor, because we realized stand trial the phase 3 studies, which were a lot more expensive, that unfortunately that the drug was no better than placebo. The voxelotor study was slightly more complicated. The initial HOPE studies, which we were heavily involved with in Imperial, were really quite positive. Unfortunately, there were 8 deaths, all in sub-Saharan Africa, in the subsequent studies looking at voxelotor. And I've seen some of that data, and part of it is trial design again. Part of it is the way in which the studies were followed up. And as a consequence, I think that we kind of taken a massive step back with both of these drugs. And we need to make sure that going forward that all studies for new sickle drugs, one, include a diverse population of patients across the various continents to ensure that we can mitigate some of the nuances of our healthcare system, but also that we try and engage with our patients to be willing to support these studies, because without them, we have nothing. So I think I'll finish there to say that this is a very exciting time for sickle, that we have new options, curative, transformative, disease-modifying options, which I hope will ensure that all our patients get the quality of care that they need. We do also need to be mindful of the fact that there are numerous barriers to treatment for our patients, and not forget that, so that we can try and overcome them, so that as many of our patients who need some of these really quite transformative options have them available to them. And we need to make sure that the pathways to access those options are as encumbered, so there are fewer challenges to patients engaging with healthcare as possible. And then finally, I think, as always, education of patients, education of healthcare practitioners, education of policymakers, people who make the decisions and decide who gets the money, is vital. I'm always quite taken aback as to how little the society, the community more generally understands. I'm quite taken aback as to how little practitioners who aren't embedded in the disorder know about sickle. And as a consequence, there's a lot of mistrust, a lack of empathy amongst those groups. And I think our patients suffer as a consequence. And I'll leave there. Thank you.
Thank you, Dr. Okoli, for the lovely presentation. I have a question regarding hydroxycarbamide. Is there any evidence linking the hydroxycarbamide use with the development of AVN, or even the progression of AVN, or even prevention of AVN?
Sorry. Yeah, that's a very good question. This is always a very contentious thing. There haven't been any studies looking at this. However, there is often this association with the development of avascular necrosis and hydroxycarbamide. I'm one of the people that don't really see this, because one of the things that several things that hydroxycarbamide does could actually limit the development of avascular necrosis. Improves, as I sort of alluded to in one of my slides, it improves the blood flow through the vasculature, it reduces sickling, it reduces the stickiness, the adherence of the cells. So all of those should mean that actually in those terminal vessels that feed the femoral head or the other joints, avascular necrosis should be less likely. However, I can't dispute the fact that there are patients that they start hydroxycarbamide and very soon after that they develop avascular necrosis. So I would suggest because there isn't any evidence, and I suspect there isn't going to be a clinical trial to try and tease that particular element out, I would go on a case-by-case basis. And if a patient develops avascular necrosis temporarily, quite soon after starting hydroxycarbamide, then I would be a strong advocate of stopping it and going with an alternative therapy. And in reality, that is, at least for now, it's transfusions. But I take your point, and I think it's a very difficult one, but I certainly wouldn't want to limit, because we've got so few options for our patients at the moment, certainly wouldn't want to limit the use of hydroxycarbamide to a group of patients because of this concern about AVN.
Is there any other questions?
Thank you, Dr. Okoli, for your presentation. My question is quite straightforward. For the patients on the treatment, which you have touched on the penicillin for prophylaxis, how about those patients who have penicillin allergy? What is their option in terms of antibiotics?
So the guidance are for those patients who are allergic to penicillin, so erythromycin is a second-line option for those patients. Yeah, that's pretty much it, really.
Yeah, just a quick one. Thank you for your presentation. I just want to find out, is there a link between hydroxycarbamide and leg ulcers?
So a similar thing to the avascular necrosis, that there is but an additional nuance, to be honest, because as I touched on in the presentation, that one of the issues with particularly with leg ulcers is the nitric oxide depletion. So one of the reasons that people develop leg ulcers is because those blood vessels become quite stiff because their nitric oxide deplete. They can then start to develop leg ulcers. Hydroxycarbamide is a nitric oxide donor. So again, as I said, in relation to the response regarding avascular necrosis, that instinctively you would expect to see those patients on, you would expect hydroxycarbamide to reduce leg ulceration. However, we do see patients develop leg ulcers quite soon after going on hydroxycarbamide. And those patients you would have to treat with caution. Again, as I said regarding AVN, I would take it on a case-by-case basis. If someone developed leg ulcers soon after hydroxycarbamide, I'd be very cautious. I certainly would try to put them on a transfusion program as soon as possible to try and help that leg heal. And then have a quite frank conversation with that patient about what, from a disease modification perspective, you'd want to try after that. You'd have to have a very careful discussion about whether you would want to reintroduce hydroxycarbamide and see how they responded as a consequence of that. But you would have to be really, really cautious. But again, sort of pharmacologically, the way in which a drug works, you wouldn't expect it to cause avascular necrosis or to cause a leg ulcers. There is some evidence, anecdotally, that happens. So you have to take it carefully in those patients that developed a soon after starting drug.
Okay, well, we'll try and keep it under 15 minutes if we can. Whistle-stop tour of the clinical trials team, who we are and what we do. And thank you, Stephen, who has already spoken quite comprehensively and expertly about a lot of the treatments. So we won't need to go into too many details about those slides, but just by way of introduction, my name is Susie and I'm a senior clinical research practitioner. And I work at the non-malignant hematology clinical trials unit at Imperial College. We're based at Hammersmith Hospital.
And I'm Charlotte and I'm a clinical research nurse.
So our unit that we work in covers a few different conditions and disease areas. So today we'll only be talking about sickle cell, but just so you're aware, we cover a few different non-malignant hematology conditions. And there are some symbols that will appear on some of the slides, but I just wanted to stop and talk through some of them a little bit, because just to give any of you who aren't too familiar with research a bit of a background, there are lots of different types of clinical research. And I know our team has clinical trials in the name, and we've talked a lot about trials, but I think I want to just talk a bit about how clinical trials aren't always drug trials, and research encompasses quite a large range of activities that we run in our department. For example, on the actual drug side of things, we have oral tablets that patients can take at home. Often these are once a day treatments. Clinical trial treatments can be a lot more complex, like the stem cell transplant studies that Dr. Okoli spoke about. Some require IV infusions. Some of them are once a month, once every 3 weeks. It really depends. People could be getting subcutaneous injections and or gene therapy. And some of these more complicated treatment types require a slightly larger time commitment from the patient. So overnight stays at the hospital, closer monitoring, whereas others like the oral daily tablets can fit in a bit easier for people's daily lives. So there's a lot that patients need to consider before signing up to anything. And I think just on the background of signing up for trials and what that really means, I want to just mention the concept of ethics in research. Stephen's spoken about known historical mistrust among certain communities in healthcare, and with good reason. And a lot of work has been done over the last few decades to try and, correct that. And there's a lot of standards and international regulations in place that we have to adhere to before we can even consider recruiting anyone to a clinical trial. And I think the main thing that I want to mention today is that we as a team really emphasize to patients that it's their choice completely whether or not they take part in research. And informed consent is only meaningful and real if it's completely and utterly voluntarily given by the patient. We encourage patients to speak to family, friends, their GP, do their own, reading around before we do any research activities with them, because it's really important that they truly understand and think that it's the best option for them at that point in their life. And, we've had patients who think that it might not be right at that point in time, but want to be maybe reconsidered in the future. It's quite a big decision for some people, for some of our research studies, because like I said, some of them do involve a commitment that not everyone is able to commit to, such as taking some time off work to attend clinic visits. Some of them are quite long. It's quite a few hours if they have intensive monitoring and follow-up. Some clinical studies are funded by pharmaceutical companies and offer some compensation like travel reimbursements, but that's not enough for people who might have more serious considerations around, employment, taking time off work. And yeah, we do appreciate that it is a huge contribution that patients and their families and carers make when they take part in research. So it's a decision that's not taken lightly.
Just to add to that, the language that we use when we consent patients is that we receive their consent, not that we consent them. And I think that is an attitude that I've really enjoyed embracing, coming from being completely clinical into research as a nurse. And I think it's something that I would love to see adopted in nursing practice, is the idea of receiving consent from a patient and making decisions alongside them. And also that if you ever did encounter any of your patients who were on trials, that they can withdraw at any time for any reason, and that applies to all research. So there's never any pressure for a patient to continue.
Exactly. Receiving patients' consent isn't a one-time event at the beginning of a study. It's an ongoing process, and it's really important for us and the teams that we work with and the patients that we see that we regularly check in that they're still happy to continue and they're still receiving benefit from it, basically. Because obviously there's the clinical markers of whether they're benefiting from it, hemoglobin and vaso-occlusive crises. But I think a huge aspect of this is how is it affecting their quality of life? And I think Stephen's slides already spoke about quality of life questionnaires being a regular feature in most studies. And it's also an attitude that I think we should try and embed in our like day-to-day experiences. Shall we go to next few slides? So the main category of clinical trials that you're probably aware of and have heard about are what we would call interventional studies. And these are clinical trials of investigational medicinal products, basically drugs that aren't yet licensed. So most of these are looking into whether a drug is fully safe, effective, and better than the current available treatment options. And the way that we need to be able to measure that is normally with a placebo-controlled randomized study, which means that when we recruit patients to this type of clinical trial, we need them to understand that they might not get a study drug, they might not receive any benefit whatsoever, and they're agreeing to contribute to the development of healthcare science and healthcare research. And the benefit might just be to future patients down the line rather than them in the immediate moment. And that also means there's obviously known as well as unknown potential risks and side effects associated with taking part in clinical trials with investigational medicinal products as well. So they're very heavily, closely monitored, and we do a lot of blood tests and other assessments very frequently.
So these slides are just our generic slides about the trials that we have open. So I think we'll breeze through them because they're a bit heavy.
And some of them aren't even for relevant conditions. So that's for thalassaemia, not for sickle cell. This one, again, Stephen already spoke about it. Our slides are split into what we call inclusion and exclusion criteria, which I think Stephen really helpfully put into layperson terms earlier as suitable candidates versus contraindications. So even if a person is really interested and willing to participate in research, they might not be able to for some reason or another, such as, for example, there might be blood tests that aren't within certain parameters that are deemed safe for them receiving an experimental drug. This is the upcoming study for the new generation of the discontinued voxelotor drug, osivelotor, and I will be the primary coordinator for this one, working alongside Dr. Okoli as a primary investigator. So if anybody here thinks they have suitable patients to refer over, do just get in contact with myself afterwards.
Yes, and Stephen also touched about the redress trial that I coordinate. It's been so fantastic being able to offer patients a curative option that they wouldn't otherwise have access to, considering this is the half-matched or haplo identical stem cell transplant. This has been one of my favourite to work on.
And I just also wanted to make sure that today we talk about the other kind of research that we do, which is just as important as developing new drugs. And this is observational, observational research. So these are studies that look into patients' experiences of healthcare without giving them any kind of new or different treatment. So these are the two that we currently have open and we're recruiting for at our site, and they are fairly similar. So I'll just give some top level stuff that covers both of them, I think. So these studies are both looking into improving Black health outcomes, which is the name of one of them. And this one is run by the NIHR, which is the National Institute for Healthcare Research. Side note, interestingly, Stephen recently did a fascinating short film documentary with them about mistrust in healthcare research and also, you know, improving and overcoming that. So if any of you are given the opportunity to watch that film, I don't think it's widely available online, so we might have to dig around a bit. There was a special screening we had at our hospital a few months ago, but it's a really, really fascinating topic and really important and pivotal to this work, where you have to think about all of the environmental factors that drive someone's willingness to take part in research and why they might not be so willing, both in terms of research and wider trust in healthcare system and NHS in general. So these two particular studies mostly function through questionnaires, which sounds quite straightforward, but they're actually working on some really important long-term aims. So they're kind of I think they also take a saliva sample, both of them, or one of them does, to look at if we can find any links and any new genetic predictors of disease, diagnosis, but also response to treatments potentially. So because there's been historical underrepresentation of Black, African and Caribbean people in healthcare research, both of these are aiming to redress that lack of inclusion, to build a wider database to try and understand links between wider things like socioeconomic status and employment, health and lifestyle, even experiences of discrimination and past childhood trauma, and how all of these have known long-standing associations with health outcomes. And these studies look specifically into how that might be linked to people's experiences of sickle cell disease and their responses to treatment. So it's observational, but it's incredibly important work, and it's looking to deeper understand patients' experiences of healthcare, of treatment, and how our understanding of that can help shape improving it in the future. I don't know if you had anything to add to that.
No, I was maybe just going to speak quickly about the role of being a research nurse. It's very, very rewarding and difficult at the same time in a completely different way to normal clinical practice. I've actually found that I really, really miss the patient contact. So there's a lot less of that, but the contact that you do have is so incredibly meaningful. So if there were any nurses in here that were thinking about becoming research nurses, I truly feel like a scientist for the first time in my career. And I think as nurses, we are scientists. And contributing to the healthcare of the future, and knowing that the things that we are collecting data on and doing a lot of paperwork for are going to be normal everyday practice in the future is really incredible. Yeah.
And I think just on that, I think it's really great to get the opportunity to speak to all of you nursing colleagues today, because I don't come from a nursing background, and a lot of the work that we've been involved in our team is trying to find ways to better integrate research into everyday healthcare, so that everyone as part of the multidisciplinary team has some kind of awareness of and understanding of what research is, so that it's not this kind of big, scary, different thing that sits outside of normal standard of care. And I think as part of that work, it might be worth mentioning that our team also runs sort of community engagement events, patient and public engagement events. I don't think we have a specific one to plug at the moment, because I think there were some issues with dates and venues.
We do have an Instagram. So we're at Imperial Heme Team. So you can see the events that are open to the public with a free lunch.
And I think I'll pop our contact details up there as well. So if anyone wants to reach out to us and ask about any future opportunities, this is how you can reach out to us or the clinicians working in research at our hospital.
I have time.
Thank you so much, Susie and Charlotte. Before we break for lunch, I'll just open it up to the floor if anyone has any immediate questions. I guess one of the old chestnuts is, given the patient population's inclination towards having significant concerns about trials and research, how do you guys work with that? I know that sometimes you have challenges in terms of being able to recruit people onto the trials.
Yeah, something that I personally have found helpful, especially talking to patients about the redress trial. I've never before in my career been like back and forth, had emails with patients and just been so open to communication, but letting them know that they can ask questions at any time before, during or after the consent process, I think has been the most beneficial for them, especially with redress it being a curative therapy. I find that patients are really eager. They want to sign up, and then afterwards, when they're waiting for a few months before the transplant's happening, then they have a lot of questions, and actually that's when the relationship building and the trust is made, is just that continuous process of being open and available.
And just something I wanted to add is that I feel really strongly that my job is not to persuade people to take part in research. So the main thing for me is just providing information and giving patients time and space to sit with that, absorb it in their own way, in their own time, and come to us when they're ready and like enthusiastically want to take part. It's not something, I think, to be honest, if people have really valid and understandable concerns, we do as best we can to explain, you know, what we can to, I don't know, it's hard to word this, but basically sometimes the answer is just your concerns are valid and you don't have to do this. But I think something that is becoming more readily available with clinical trials and the companies we work with is really nicely, like, easy to read, like visual, digestible information about something that can be really, really complex, a bit scary, and sort of making it seem as accessible as possible. And it might be something as simple as a short video, a poster with a diagram. But I mean, I know I find my learning is easier with visuals. So Stephen's slides with this is what this drug is actually doing and how it might benefit you and how it works might be a lot better than just saying, you know, here's a long list of side effects. This is a drug that you could take, and just, yeah, it's about individual relationships with different patients, understanding what they respond to best and providing them with as much information as is possible without overwhelming them in appropriate timeframes and giving them time to digest and make the best decisions for themselves, I think.
Perfect, thank you.